Hello, everyone. Thank you for joining. We are kicking off today with looking at vitreoretinal surgery. And I thought a good place to start would be looking at your posterior vitreous detachments, and retinal tears. So you'll find this in the sort of urgent care playlist, as well as our vitreoretinal surgery playlist. So we're going to go through just touching on the anatomy of the retina, specifically looking at the peripheral retina, your vitreous, where does it actually all sit in the normal eye? I'm also going to give you some examples of things that you may find when you're doing a posterior segment exam, and which things that are typically sort of low risk when you think about developing into a retinal break or retinal detachment, and things that are slightly higher risk. How do PVDs develop? How do they present? What do we do about them? And then we'll touch on retinal breaks as well. I'll do a completely separate session, which will look at retinoschisis and retinal detachment. It's a very involved discussion, so I wanted to sort of focus today's session specifically looking at PVDs and retinal breaks, and how to manage them. So starting off with your peripheral retina, this is a diagram of an eye. Now, obviously, this is someone's eye who's not in the socket, but essentially, behind your limbus, you have the ciliary body. Now, this starts at about 1 millimeters, but 1 millimeter behind your limbus, and it extends for about 6 millimeters. And your ciliary body, if you remember from your anatomy, is made up of two parts. You've got the pars plicata, and then the pars plana. Now, your pars plicata is about the first 2 millimeters of your ciliary body. It's the much wider bit. And then you have the flat bit, the pars plana, which is about 4 millimeters. So if you think about the pars plana, it starts at about 3 millimeters away from the limbus, which is where you're typically going to get these, between 3 to 4 millimeters in terms of where you're injecting for intravitreals, or where you're putting your ports for vitreoretinal surgery. And that's why it's important to know that's essentially where you're coming in through in the pars plana. Now, when you're actually looking at your vitreous actually starts where you're more closer to your ora serrata. So the ora serrata is basically just the junction between your ciliary body and the retina. And the vitreous base sort of straddles this area. So it sits kind of just at the junction between your pars plana and your retina, and it sits just there. And when we're doing these incisions, where we're coming in, if you look at roughly where the X is, that's kind of roughly where we'll put intravitreal injections, and it's also where we put our ports in VR surgery. And so this will typically come in anterior to the vitreous base. You don't typically inject into the vitreous base itself. Now, this is a sort of magnified diagram essentially of the ora serrata. I've basically stolen this directly from Kansky. And it just shows some different things that you can see when you're looking at an indented exam. You've got the top bit here, this is the pars plana, and then that comes into the retina here. And you've got things like dentate processes, for example, meridianal folds, bays, and these are all things that you'll typically find in a normal eye. And these are not necessarily things that you need to treat, but sometimes they can look like breaks. So with a good indented exam, you'll be able to tell the difference between what is a break and what is just essentially the junction between your ciliary body and your retina. So to kick off with some harmless lesions, I've got some pictures of a few of these. So microcystoid degeneration is something that you'll actually see really commonly. So this is actually, you'll see this in up to, the majority of eyes, especially in adult eyes. And these are completely harmless. You don't need to do anything about this. And that's typically what it looks like. And you may come across this quite often, actually, in patients when you're doing a peripheral exam. Paving stone degeneration looks more like this. You've got these specific discrete areas, again peripherally, and again, this holds a very sort of low risk when it comes to causing a break or a detachment. Honeycomb or reticular degeneration looks a bit like this. And then you've got a sort of peripheral drusen. Couldn't find really a very good picture of that, but it basically looks like drusen, but right out into the periphery, completely asymptomatic and harmless as well. And pars plana cysts are these flat cysts right at the very edge of your retina. You'll see that if you've got a very wide field lens, or if you're doing some indentation. Whereas your predisposing lesions, these are lesions that actually can potentially develop into breaks, can potentially cause problems. So lattice degeneration is your typical thing that will be mentioned when you're looking at stuff like this. So you're looking at something like a myope, for example. These are patients who typically have something like lattice degeneration. It usually develops a bit earlier in your life. And basically, if you have lattice degeneration, you're looking at approximately a 1% lifetime risk of a retinal detachment. But interestingly, if you flip the statistics, if you're looking at patients with retinal detachment, about 40% of them will actually have an area of lattice. And that's why patients who actually have the retinal detachment surgery will then have an area of lattice that's being treated, even if there isn't a break. And essentially, what lattice is a discontinuity of your internal limiting membrane. And then you've got sometimes some atrophy of the underlying retina as well. It's usually bilateral, and you're kind of looking at, your peripheral retina in terms of where these things, where you're most likely to find lattice. You may find some tears within them. And sometimes with most patients, if they're asymptomatic, you don't need to do anything. But if there is a tear, or if they are symptomatic, sometimes it is worth treating these areas of lattice either by lasering around it or actually applying some cryotherapy. Now, snail tract degeneration is actually completely harmless, but the reason I've put it here is because there is a belief that it's essentially a sort of it is a precursor to lattice degeneration, which is why I put it here. But it by itself is usually not a problem at all. Cystic retinal tufts essentially look like tufts, but they're more 3D and they're cystic in nature, and these can cause breaks and these can develop. Retinoschisis, like I said, I'll go through at a later date. And interestingly, what zonular traction tufts are zonules that extend posteriorly onto the retina and can cause pulling on the retina. Then, when it comes to white with or without pressure, this is a term that you may have come across. And basically, what it describes is an appearance of the retina that is either seen with indentation or with no need to indent. And basically, it will be a discrete area in the peripheral retina that is quite white compared to the rest of the retina. And it basically just signals an area of the vitreous which is much more bound to the retina underneath it, which is why there's a bit more traction. With or without pressure basically means without pressure is an area of the retina that you're seeing on a posterior segment exam with a lens. With pressure is specifically when indenting. As you indent, you'll see an area of the retina that becomes white, and it doesn't move as you move your indenter. It will stay where it is, and the edges will stay discrete. And then finally, myopic choroidal atrophy. These are kind of areas of choroidal atrophy that you'll see sometimes either centrally or peripherally, and this very thin retina can then break and then cause retinal detachments. With white without pressure, like I said, because it's a much kind of stronger adhesion of the vitreous. It means that when there is a PVD, because it's a stronger adhesion, it can cause a tear as it comes away. So when you're looking at the vitreous is essentially a gel, as you may know, and there are specific adhesions that that gel has to the rest of the eye. So, in sort of order of strength, you're looking at the vitreous base, which is basically along this, where I mentioned, if I go back to that specific diagram right at the start, your vitreous base is there straddling the ora serrata. So it straddles just the distal part of your pars plana and the very, very proximal part of your retina. And that vitreous base, your vitreous does not come away from that. It just doesn't. So even when you're doing a pars plana vitrectomy, you trim your vitreous as close as possible to that area of the vitreous base, but that vitreous does not come away. And this is why sometimes pre-existing breaks within the vitreous base are actually completely harmless and they don't progress because the vitreous doesn't come away from on top of it. Your next most kind of strong adhesion is probably at the optic disc margins. Then you're sort of looking at perifoveally, the peripheral vessels, and then finally you have this very loose adhesion to the internal limiting membrane, which obviously comes away as you get a PVD. Where things are a bit more pathological and you don't have a normal connection is where you're looking at areas of lattice, which is why they're high risk, white with or without pressure, again, which is why they're high risk. And in patients where you have, for example, vitreomacular traction, that is somebody who has a slightly more strong adhesion to the retina, which is why you're actually seeing these things develop. Now, when you're looking at vitreous detachment, this is basically a normal process. Okay, it happens in everybody. It happens at slightly faster rates depending on the type of eye and what has happened to the eye, but it's basically the separation of your posterior hyaloid membrane or the posterior hyaloid face. That's the posterior edge of your vitreous, the posterior face of your vitreous, and it detaches away from your neurosensory retina. Now, where that starts is just perifoveally. The fovea then comes off, and then it spreads around the peripheral retina, and then right at the end, the edges of the disc come off, and that's where you start to see this vice ring that's mentioned. Now, it's a very natural process, like I said, but certain things speed it up. High myopes, for example, trauma to the eye, surgery to the eye. These are all things that can speed up the development of a PVD. And up to 10% of all PVDs will have a tear in place, which is why these tears are very, very frequent and why it's important to actually look for them. Now, the thing to bear in mind is that number changes dramatically when you're looking at a PVD that is hemorrhagic. So if somebody has had a posterior vitreous detachment and they have a bit of bleeding in the vitreous, that 10% can actually go right up to 70 to 90%. So you really ought to be very, very careful when you're looking at somebody with a hemorrhagic PVD. So how do they present? This will be, the patient will come in with your usual flashing lights and floaters. And basically what's happening with your flashing lights is if you think about your retina as a sensory tissue, and this is how I explain it to patients, if I were to pinch your skin, you perceive that as pain. Whereas if I were to pinch your retina, you are going to perceive that as flashing lights. And that's where you're getting these flashing lights from. It's as that vitreous comes away from the retina, causing a bit of friction, a bit of traction, sorry, and you get these floaters as well. There is a possibility of having some blurred vision, and that's especially the case if you're in the context of a hemorrhagic. And what you can sometimes see on an examination is you essentially see this posterior hyaloid membrane separation. Now, you can actually usually see this without the lens. So you focus in into the pupil, move forward into the eye, and then you can see the vitreous face floating about, and that kind of gives you a marker that that PVD has already occurred. Or with the lens up, what I usually tend to do is focus on the disc and then come forward. And then with focusing on the disc and coming forward, you'll eventually come across the vice ring, which you can see, and that's the very edges of the disc. And that tells you essentially that somebody has a complete PVD. The other thing that you want to look for is, like I said, any evidence of any hemorrhage or in the anterior segment or the anterior vitreous, sorry, you'll be looking for some tobacco dusting. And again, that's because it's a slightly more concerning sign that this is a PVD in the context of a retinal tear. So what should you do? You need to do a very detailed exam, get a nice dilated 360-degree exam. And the guidelines really are that in a patient with flashes and floaters, you really ought to be doing an indented exam so you can see right up to the vitreous base and see whether or not any tears are visible. You can consider doing an OCT that can help you see whether or not the vitreous has come away from the back of the fovea. You can also see whether or not there's a shallow detachment that can be difficult to perceive either through a hemorrhagic PVD or a cataract. And ultrasounds can also help you in the context of where the view is quite poor. And again, that's either because of a hemorrhage, for example, or a media opacity, such as a cataract or a corneal scar. For a patient who just has a PVD and has absolutely no retinal breaks, my usual thing is just give them advice on what flashes and floaters are, what a PVD is, and red flag symptoms that they need to look out for in order to present back to us. Or obviously, if there is a retinal break, and we'll go into that in a moment, you need to then manage that separately. I just wanted to give a couple of pictures of what PVDs look like. So with an OCT, you can see that on the left-hand side, you can see that posterior hyaloid face, this white line here that's completely come off. And actually, you can also see it's come off the edge of the disc here. So this is a nice complete PVD away from the retina, no tractional issues at all. And on an ultrasound, again, you see this white line, which won't be as bright as you see it with, for example, something like a retinal detachment. But importantly, also with a retinal detachment is obviously you're going to see this funneling down to the disc, whereas with the vitreous will come away completely and you'll see this line coming all the way across. So I wanted to end on just talking about some red flags. So if you're seeing these things with a PVD, be on high alert that you might be looking at a tear. And if you don't find one yourself, either ask a senior to help you out, maybe ask some VR colleagues to help you out with some indentation. But you also may want to consider actually following up these patients within a couple of weeks to make sure that nothing else has happened. And this is all maybe, for example, some tobacco dusting or what they call Schaeffer's sign. So this is blood or pigment in the anterior vitreous that again should put you on high alert that the retinal pigment epithelium has has essentially been exposed, and that's what happens in the context of a tear. Vitreous cells, some reports will mention that up to 10 to 30% of eyes that have these vitreous cells in the fellow eye actually are hiding a tear, even though they're asymptomatic. Vitreous hemorrhage, like I said, that takes your, retinal tear in the context of a PVD, um, from about 10% up to about 70 to 90% according to some papers and some case reports. So be very, very careful with vitreous hemorrhages. The difficulty, of course, with vitreous hemorrhages is that they can actually also obscure the fundus. And this is why actually the threshold for doing a vitrectomy in the context of a fundus obscuring vitreous hemorrhage, or in the context of a fundus obscuring hemorrhagic PVD, the threshold of actually going in and doing a vitrectomy is a bit lower because these are patients who are probably hiding a tear behind that bleed. And a B scan can help you. An ultrasound can help you look at to see whether or not the retina is attached. And for, particularly larger breaks, especially, you can sometimes see the break on the ultrasound, but seeing a break can be very difficult. So even if you don't see one, and a fundus obscuring vitreous hemorrhage can be a reason why somebody actually goes in and performs a vitrectomy, because the risk of them hiding a tear underneath and then causing a retinal detachment is much higher. So we'll start to talk about retinal breaks now. Um, so you're basically most of the time seeing a retinal break in the context of traction caused by the vitreous, and that's usually a PVD. You can also see them in the context of, for example, trauma or surgery to the eye, complicated cataract surgery, and actually you'll find that retinal breaks exist in about an eighth of patients. Now, that doesn't necessarily mean that you're treating all of them because retinal breaks range from completely harmless ones to things that are more high risk. So what you can see here in this picture is your typical horseshoe tear that's been lasered, but retinal breaks also, is an umbrella term that looks at breaks that actually are also harmless, which is why this 12.5% is the understanding. And the incidence of retinal breaks, I've said this before, but if you have a PVD that is symptomatic, so lots of patients have PVDs and have no problems, but if a patient has a symptomatic PVD, that increases the risk of having a retinal break. Because in the context of a PVD, your retinal break sits at about 1 to 2%, maybe up to 5, but in a symptomatic PVD, that can go up to about 10%. So um, be wary if somebody is symptomatically complaining of a PVD. So you're typically going to find them supratemporally, but they can be anywhere in the eye, and they can be associated with a small amount of subretinal fluid, and that's just because the break allows this retrohyaloid fluid to just come in behind the retina, and that's why it can then develop into a retinal detachment. Usually, if there's what's said is if you've got less than 1 disc diameter's width of SRF, it's a tear. Any more than that, then that would be understood as an actual detachment rather than just a tear with some SRF. Your horseshoe tears are what you're going to come across most often in the context of a break that you treat. And this is a picture of that here. You can see it looks like a horseshoe, and that's basically a tear has happened on the retina here, and you can see this lip of retina just floating about. And these are very, very high risk in terms of them progressing, getting larger, and causing a retinal detachment. You then have what we call an operculated tear. So this is where you have a tear where the retina that's actually been torn off has completely come off. You don't have a lip like you do here. It's completely come off, and you can actually sometimes see it sitting just anterior to where the tear is. You then have retinal holes. These you might think look like operculated tears, but they tend to be much more distinct, much more discreet, and they're also usually a bit smaller than your usual breaks. Retinal dialysis is where the retina actually just comes off from the base, so right from where the ora serrata is. So you can see like a curtain, it's draping downwards, and that's just because it's just come off the base itself. And this is you'll find usually in the context of blunt trauma. Whereas with a giant retinal tear, it's a tear that extends anything larger than 3 clock hours. And you can see that at first glance, this may look like a dialysis, but if you look at it very carefully, hair on the temporal edge of that break, you can actually see a corner to it. And there's actually a break here in the retina itself. And that's quite a large break. Whereas with a dialysis, your edges of the dialysis will go right up to the pars plana. You don't actually have a tear per se, but the retina has come off. And that could either be just a dialysis of the peripheral retina, or it could just actually also be a detachment as well. And that's the same with the giant retinal tear. Now, these are very, very dangerous. And with giant retinal tears, they can be very difficult to laser because of how big they are. So sometimes giant retinal tears are actually requiring more things like a cryo or a buckle to treat them, because of how big they can be. Now, when it comes to managing a retinal break, importantly, we're not talking about specifically horseshoe tears here. We're talking about retinal breaks in general. You're essentially managing risk, and you're looking at the risk of the patient and deciding whether or not a break needs treatment. And when you're looking at risk, you're looking at factors that can increase the risk of a tear causing problems. So you're looking at things like, have they had a previous retinal detachment? Is there a family history of retinal detachment? Are they pseudophakic? Did they particularly have complicated cataract surgery? Are they a high myope? Do they have something like a Marfan's or Ehlers-Danlos? Do they have any upcoming surgery? So are you looking at a patient who's about to have some laser? You're looking at a patient who's about to have a vitrectomy, about to have cataract surgery. Are they symptomatic with it? Is it a larger break? Do they have any traction around the break? And then I'm also going to go into some detail with the shape of the tear itself in terms of how risky they are. But these are all factors that make you think this is somebody who's a slightly higher risk patient. I'm going to want to just be, give my mind some assurance and actually just treat the break itself. But if you have a small round retinal hole in a patient who's otherwise completely well with no risk factors, you would just leave that alone and discharge them with essentially safety netting advice. When you're looking at the shape of the tear, your U tears are basically the most dangerous. You're looking at if they're symptomatic, you're definitely going to treat them. If they're asymptomatic, to be honest with you, the majority of the people I've spoken to will still treat asymptomatic U tears. There are some people who would, debate that and say that actually they can just be monitored. And there are factors that would make you want to do that. Is it inferior? Is it completely asymptomatic? How long has it been there? It's not caused any problems. You may want to consider reviewing it because the patient doesn't want laser for whatever reason, but most people would laser a horseshoe tear. Operculated tears can usually be monitored because they've completely come off, and if they're round and they're flat, these are usually not that risky in comparison to a horseshoe tear. But again, the factors that I've discussed before may want to make you treat it. So things like previous retinal detachments, many breaks. These are all reasons why you may want to consider treating them. Traumatic breaks are usually completely always treated. Dialysis typically needs a surgical management to actually put that retina back in place, and round holes usually can be monitored as well. So, how do you treat a break? You're basically either burning it or freezing it. So, for the vast majority of breaks, if they're not too anterior and you can actually see them with a lens, you're basically going to laser them. Now, the settings are quite similar to a PRP. Your spot sizes, you're looking about 300 to 400 microns, but you alter what it is on the machine depending on the lens that you're using. But you typically use a slightly higher power. You're wanting to get a really, really nice, bright reaction. With PRP, you're typically looking at a sort of moderate reaction. You're not kind of wanting a really kind of white, bright reaction. But with when you're doing retinopexy, you really want a nice, bright reaction. And you're going to then give them confluent burns for about 2 to 3 rows. So if you remember the picture that I showed you here, you've got somebody here with a really nice, bright reaction, 2 to 3 rows right around the tear, of basically confluent burns to essentially stick that part of the retina down and try to prevent it from breaking away. Um, with cryotherapy is basically you've got minus 85 degrees, you right up against the sclera, and it freezes everything down. And you're typically using cryotherapy either intraoperatively for quite anterior breaks, or even, for example, just completely anterior breaks where you can't laser because for whatever reason, a media opacity, for example, or it's just a really peripheral break that you can't reach with a lens. Cryotherapy can be really helpful because you use the cryotherapy to indent the eye, you get a view with an indirect ophthalmoscope, and then you apply the freezing therapy. The important thing when you're freezing is that when you're freezing it, you get this white reaction of the retina, and you want that reaction to go completely around the entire break. You want the entire edge of the break to get this freezing therapy. And then when you come off the cryotherapy, you don't come off the eye immediately because what you can basically do is just take sclera with you. So you want to wait until it thaws and then slowly, gently come away. And you basically want it to come away from the eye itself. So don't just pull away from the eye as soon as you've applied the freezing therapy, wait a bit, and then come off. Once you've lasered these patients or once you've cryoed these patients, you're basically telling them, listen, avoid strenuous exercise for a couple of weeks at least, and then we're going to review you in 2 weeks as well. And the reason you review in 2 weeks is because those 2 weeks are usually the highest risk. Because when you burn these patients, the initial reaction of the retina is actually a slight swelling, which can actually make things a bit more likely to detach. So those first 2 weeks are really important. It's only after the couple of weeks that everything really scars down and then that break becomes nice and safe. So that 2 week follow-up is usually very good. And it's also because the laser itself can actually cause a break as well. So what you want to do is see them in a couple of weeks, do another nice 360-degree exam, and just check you've not actually caused problems as well. So that basically brings us to the end. Essentially, the summary is there's lots of different findings that you can find in the back of the eye. And the important thing is having it in your head, which things give you slightly higher concern for the development of a break and the development of a detachment. And your careful examination is really important. Get yourself a nice wide view lens. Get the patient dilated. If they're not dilated well enough, put some more drops in. If they're at their absolute maximum, get a nice 360-degree review. And if you're not getting right out to the periphery, then indent them with an indirect and actually really look at the entire retina up to the pars plana. And then depending on the type of break that you're seeing, depending on the eye, depending on the patient's history, depending on the upcoming treatment for the eye, stratify that risk and then decide whether or not this is a break that needs treating, or if it's a break that can be monitored, or if it's a break that can actually just be discharged with safety netting advice. So thank you very much. In the future sessions, we'll look at retinal detachments as well, and we'll go through those in a bit more detail. But I wanted to focus just taking a step back on the barn door things that you're looking at here with posterior vitreous detachments and then the retinal breaks as well. So please do remember to give me some feedback. There's a link in the description below. And as always, we will see you at the next one.